Hi everyone, this is the Pulmonary Physiology lecture for Anesthesia Principles. So here are our objectives for this lecture. We're going to review basic pulmonary anatomy, structure, and function. We're going to look at mechanisms of ventilation and oxygenation. We're going to analyze mechanisms of gas exchange, and then integrate those concepts into anesthesia practice. So this was an infographic I obtained from Jay Shetty's masterclass, and the topic of the class was navigating through change. And he says, tie your identity to not what you do, but how you do it. And starts at the top with learning, experimenting, perform that skill or task, and then you're going to struggle because you're learning and you're new and a novice. You want to start back over again and then integrate that information you're learning. And I feel like this is a decent framework for this semester where we're going to learn content, experiment, and apply that. You're going to perform these skills and apply this knowledge in the clinical setting. And then there's going to be a opportunity for growth. And then eventually, hopefully, once you've mastered everything, thrive in your career as a CRNA. So I think it's helpful to have a concept overview for this lecture because there's a lot of information. So we'll start with anatomy, touch on respiratory physiology, look at oxygenation, ventilation, and then perfusion. So here's an image of the anatomy of the lungs. The lungs are obviously paired organs in the thoracic cavity, and they're separated by the heart and other structures in the mediastinum. The cephalad portion is considered to be the apex and extends 2.5 centimeters above the clavicle. That's important to remember when you're doing supraclavicle nerve blocks, to remember that your lung pleura reaches above the clavicle, and you'll see that on ultrasound. And then the caudad portion of the lungs is considered to be the base, and they rest on the diaphragm. The lungs receive the bronchus, blood vessels, lymphatic vessels, and nerves through a slit in the mediastinal surface called the hilum, and the structures entering the hilum constitute the lung roots. So next, moving on to the anatomy of the pleura. And the pleura is a serous membrane that folds back on itself to form a two-layered membranous pleural sac. The outer layer is called the parietal pleura and attaches to the chest wall, and the inner layer is called the visceral pleura and covers the lungs, blood vessels, nerves, and bronchi. There's no anatomical connection between the right and left pleural cavities. With the addition of pleural fluid, the lung pleura allows for easy movement of the lungs and inflation during breathing. The pleural cavity is the space between the visceral and parietal pleura, and the space contains a tiny amount of serous fluid, which has two key functions. First, the serous fluid continuously lubricates the pleural surface and makes it easier for them to slide over each other during lung inflation and deflation. And then the serous fluid, the second function is that it generates surface tension, which pulls the visceral and parietal pleura adjacent to each other, and this function allows for the thoracic cavity to expand during inspiration. And when lung compliance is reduced, larger changes in pleural pressure are needed to create the same tidal volume. So patients with low lung compliance breathe with smaller tidal volumes and more rapidly, making spontaneous respiratory rate the most sensitive clinical indicator of lung compliance in a spontaneously breathing patient. So here you see a picture of the right and left lung, and you can see on the right side, right lung is broken up into the upper, middle, and lower lobe, and then the left lung is broken up into the upper and lower lobes. Of note, the right lung is larger and weighs more than the left lung. And also, I think it's important to note that the right main bronchus is wider and makes a smaller angle with the long axis of the trachea. And that's important because if you ever inadvertently advance an endotracheal tube too far past the carina, the endotracheal tube is going to preferentially go down the right main bronchus, and that's why you should listen to breath sounds after you intubate your patient. Of note, the trachea extends from level C6, right around the cricoid cartilage, to the carina, which is approximately located at T4, T5. And in adults, the approximate length is 11 to 13 centimeters, with approximately 2 to 4 centimeters being extrathoracic. The trachea has 16 to 22 horseshoe bands, or C-shaped cartilages. And the posterior tracheal wall lacks cartilage and is supported by the trachealis muscle. So here's another image of the thoracic cavity, and I listed this picture from Netter so you can visualize how the lungs and pulmonary circulation, where they're placed in relation to one another. So you can see how the superior and inferior vena cava are in front of or anterior to the trachea. And then the aorta dives back behind your pulmonary vasculature. So next, looking at the tracheobronchial tree, I think this picture to the left is really important to recognize that that's your carina. So if you're ever going to be doing a flexible fiber optic intubation, you want to be able to visualize this distal end of the trachea. And then the image on the right has each right and left main bronchus broken down, and then the divisions from there into each lung lobe. I think this is really important to know what you're looking at, particularly if you ever intubate too far. You can place a fiber optic scope down your endotracheal tube and visualize if you have secretions or if there's an occlusion, or if your tube depth is appropriate or not. So before air reaches the alveoli, the air is warmed and humidified by upper airway structures. There are different respiratory cells that we have in our body. There's ciliated epithelial cells, and these are the most abundant. And there's two types. There's basal and secretory cells. The basal cells are stem cells responsible for producing new epithelium, or goblet cells. Goblet cells produce mucus, and then mast cells are most important for bronchoconstriction. So let's talk about gas exchange. And I think there's three things to keep in mind when you're considering gas exchange. First, you need to have ventilated alveoli. Second, any type of gas, oxygen or carbon dioxide, need to be able to diffuse across the alveolar capillary membrane. And then third, there needs to be adequate circulation of the pulmonary capillary bed. So the image to the right here is the oxygen pathway of respiration, the drawing of an alveolus adjoining a pulmonary capillary where oxygen and carbon dioxide are exchanged. Blood flow exiting the alveolus enters arterial circulation on the right and crosses through the interstitium and tissues and returns to the pulmonary capillary through the venous system on the left. Partial pressure values are listed in millimeters of mercury. Again, there are approximately 400 million alveoli in our lungs, and size depends on lung volume. Typical tidal volume for an adult patient is 5 to 600 mLs. And then I wanted to make note of the pores of Kohn here, which provide collateral ventilation between alveoli. So here there's an image of the alveolar capillary membrane with each specific cell and different parts of the anatomy of the structure. So the alveolar capillary membrane, there's two primary functions. The first function is transport of respiratory gases, namely oxygen and carbon dioxide. And then the second function is production of wide variety of local and humoral substances. So the different type of alveolar cells are listed here. Again, these are typically capillary endothelial cells. Type 1 alveolar epithelial cells are responsible for gas exchange and tight junctions between oncotic pressure to maintain oncotic pressure. And then alveolar epithelial cells type 2, these do not function in gas exchange, but they contain stored surfactant, which is really helpful for allowing the alveoli to remain open and participate in gas exchange. There's also alveolar macrophages. So next, moving on to the anatomy of the diaphragm. This is a membranous muscle separating the abdominal cavity from the chest wall. Motor innervation comes from the phrenic nerve that is derived from C3, 4, and 5. The way I remember that is C3, 4, 5 keeps the diaphragm alive. And this is really important to consider, particularly when you're administering neuraxial anesthesia. If you ever get a high spinal and that local anesthetic gets high enough of C3, 4, 5, you might need to support a patient's respiratory status if the phrenic nerve is blocked. So during inhalation, the diaphragm contracts and flattens, which is going to decrease intrathoracic pressure, and it's going to pull air into the lungs. And then during exhalation, the diaphragm relaxes and returns to this steady state or dome-like structure that you can see here on the right. So next, moving on to respiratory muscles. So muscles of the rib cage or intercostal muscles are broken down into an external and internal group. The external group fibers run in a caudal to ventral direction from the upper rib and are deficient anteriorly, whereas the internal group have fibers running caudal to dorsal from the upper rib and are deficient posteriorly. Examples of accessory muscles include the sternocleidomastoid, the extensors of the vertebral column, the pectoralis minor, the trapezius, and the serrati muscles. And then, of course, abdominal muscles. This is the most important expiratory muscles, and these include the rectus abdominis, external oblique, internal oblique, and transverse abdominis muscles. And you'll see that when a patient's in respiratory stress, you'll see those patients, particularly pediatric patients who don't have cartilaginous ribs yet, they're really going to work, and you see those intercostal and abdominal muscles working to help the patient breathe. So again, here's just another image from Nagelhout. Muscles of inspiration are located on the left. Muscles of expiration are located on the right. Looking at lung volumes and capacities, I think this slide's really important, not only for didactic education and board prep, but for clinical application and practice. You'll often see different disease states impacting different volumes or capacity of the lung. For example, someone with COPD versus someone with asthma or pulmonary fibrosis and anesthesia. There are cases, thoracic cases, that will need one lung ventilation. So it's really important to understand this concept. We'll start with the image on the left. This chart shows a tracing that would be produced from a spirometer, particularly in the yellow shaded area. And then on the right, the diagram shows pulmonary volumes as relative proportions of an inflated balloon. So during normal quiet breathing, approximately 500 mLs of air is moved into and out of the respiratory tract, and that's an amount called the tidal volume. So when you're breathing at rest, that's a normal tidal volume. And then you don't have to write all this down because it's listed on the next slide, but we're going to go through each one of these volumes and capacities. So starting with residual volume, if I'm back on image A or picture A, the residual volume is the volume of air remaining in the lungs after maximum exhalation or expiration. The expiratory reserve volume, this is the maximum volume of air expired from resting end expiratory level. A tidal volume is the volume of air inspired and expired with each breath during normal quiet breathing or not forceful breathing. The inspiratory reserve volume is the maximum volume of air inspired from the resting end inspiratory level. So next, moving on to capacities. Your inspiratory capacity is your inspiratory reserve volume plus a tidal volume, and this is defined as the maximum volume of air inspired from the end expiratory level. So vital capacity breaths, this is your inspiratory reserve volume plus tidal volume and also includes your expiratory reserve volume. And this is the maximum volume of air expired from the maximum inspiratory level. Next, moving on to your functional residual capacity. This is your reserve volume, or residual volume, and expiratory reserve volume. And this is the volume of air remaining in the lungs at the end expiratory level. And this is really important as we're getting ready to go off to sleep and for general anesthesia. You want to denitrogenate or pre-oxygenate your FRC, or functional residual capacity, because that's going to allow the patient to oxygenate while they're apneic, while you're instrumenting the airway. So you'll hear us talk about filling up their FRC with oxygen or denitrogenating, and this is our target volume or capacity that we're working with. And then total lung capacity, this includes everything and is listed on the left. This is the volume of air in the lungs after maximum inspiration, the sum of all compartments. And again, that's outlined on the next slide. So here is a glossary of static lung volumes and capacities, everything we just went over. So closing volume, this is defined as the volume above residual volume where small airways close. And this is a phenomenon during exhalation when small airways collapse, hindering further emptying of the distal lung units. The closing volume is normally below residual volume in an individual, but increases approximately 30% of the total lung capacity at age 20 years to approximately 55% at age 70 years. And you can kind of see at this graph, on the left is the total lung capacity, age is on the right, and you see as we get older, our closing volume actually increases with age. And then conditions that increase closing volume include supine positioning, pregnancy, obesity, COPD, congestive heart failure, aging, and then anything that would decrease residual volume. So next, moving on to closing capacity. This is the absolute volume of gas contained in the lungs when small airways begin to collapse. And I want you to think about this in relation between the functional residual capacity and closing capacity, and that's going to determine if there's airway collapse. So normally, functional residual capacity, or FRC, is greater than closing capacity. However, when closing capacity becomes greater than FRC, or functional residual capacity, airway closure occurs during normal tidal breathing, which is going to contribute to intrapulmonary shunting and hypoxemia, which we'll discuss later. To reverse this process, you want to ventilate your patients with PEEP, or positive end expiratory pressure. And as we age, pleural pressures become progressively higher, so small airways begin to close sooner, and we have higher lung volumes. So with age, you have an increased FRC, or functional residual capacity, you have an increased closing capacity, increased residual volume, but a decreased vital capacity. So next, I think it's really helpful as we move into this next topic to think about mechanical ventilation and apply some of the knowledge you have from bedside nursing care. So let's start or differentiate between peak pressure and a plateau pressure. A peak pressure on a ventilator, this is the pressure that's generated by the ventilator to overcome both airway resistance and alveolar resistance. The total pressure needed to push a volume of gas into the lungs and is composed of pressures resulting from inspiratory flow resistance, the elastic recoil of the lung and chest wall, which is defined as elastic pressure, and the alveolar pressure present at the beginning of the breath. So again, the peak pressure is the pressure that's generated by the ventilator to overcome both airway resistance and alveolar resistance, and it's calculated here. Moving on to plateau pressure, this is the pressure that is left over in the lung after a tidal volume has been delivered. In order to measure this, you need to do an inspiratory hold, which some of our anesthesia machines you cannot accomplish this. So it's more of a theoretical framework in understanding pulmonary physiology. The number of a plateau pressure is reflective of the compliance of the lung. So if the lung is very compliant, as it is with patients who have COPD, the plateau pressure is lower. If the lung is not compliant, as in patients with ARDS or fibrotic lung disease, the plateau pressure is going to be high. Okay, so I'm a visual learner, which is why I included this graph here. So you can see your x-axis is time and your y-axis is air pressure. So again, reviewing briefly, peak pressures are the pressure that's generated by a ventilator to overcome both airway resistance and alveolar resistance, whereas plateau pressure is the pressure that's left over in the lung after a tidal volume has been delivered. The other pressures listed here are resistive pressure, and this is the product of the circuit resistance and airflow. In a patient being treated with mechanical ventilation, resistance to airflow occurs in the ventilator circuit, the endotracheal tube, and most importantly, the patient's airways. An elevated resistive pressure, so greater than 10 centimeters of water, suggests that endotracheal tube has been kinked or plugged with secretions, or that intraluminal mass or bronchospasm is present, which is helpful in diagnosing something intraoperatively. Next, moving on to elastic pressure. This is the product of elastic recoil of the lungs and the chest wall, and the volume of gas delivered. For a given volume, elastic pressure is increased by increased lung stiffness, as in pulmonary fibrosis, or restricted excursion of the chest wall or diaphragm, such as someone who has ascites or morbid obesity. Because elastance is the inverse of compliance, high elastance is the same as low compliance. Said another way, high compliance is the same as low elastance. So if you have an increased elastic pressure greater than 10 centimeters of water, this is going to suggest decreased lung compliance, and that can be due to edema, fibrosis, large pleural effusions, pneumothorax, extrapulmonary restriction, things of that nature. Next, moving on to end expiratory pressure. This is in the alveoli, which is normally the same as atmospheric pressure. However, when the alveoli fail to empty completely because of airway obstruction, airway limitation, shortened expiratory time, or end expiratory pressure may be positive relative to the atmospheric pressure. This pressure is called intrinsic PEEP or auto PEEP to differentiate it from externally applied or therapeutic PEEP, which is created by adjusting the ventilator or by placing a tight-fitting mask that applies positive pressure through the respiratory cycle. So let's define lung compliance. Lung compliance is defined as a change in volume divided by the change in pressure. And it's important to note that compliance changes as lung volumes change. Said another way, compliance is volume dependent. And figure 29.3 here shows the lung is less compliant at both low and very high lung volumes. So you can see here in this picture, the slope of the inspiratory curve is less at both low volumes and high volumes, signaling a decrease in lung compliance at both of these points. At low volumes, more energy is going to be required, so more negative pressure, to begin to expand the lungs. And at high volumes, the alveoli are almost at their capacity, and further changes in pressure result in less changes in volume. During the expiratory curve, or the purple curve, there is less negative or more positive pressure as the chest wall relaxes back to the resting level and the volume of air in the lung is expelled. So again, lung compliance is defined as a change in volume over change in pressure, and for a given change in pressure, a more compliant lung has a greater change in volume than a less compliant lung. So next, moving on to compliance, or said a different way, compliance is a mechanical property used to describe the elastic behavior of the lung, chest wall, and respiratory system as a whole. Transpulmonary pressure, which is intrapleural pressure minus alveolar pressure, is generally used to calculate total pulmonary compliance during spontaneous ventilation. And you can divide compliance into both static or dynamic compliance. So static compliance is pulmonary compliance at a given fixed volume when there is no airflow and muscles are relaxed. This situation takes place when transpulmonary pressure equals the elastic recoil pressure of the lung, and it only measures the elastic resistance. Compared to dynamic compliance, this is a continuous measurement of pulmonary compliance calculated at each point, representing a schematic changes during rhythmic breathing. It monitors both elastic and airway resistance. Airway resistance depends on air viscosity, density, length, and radius of the airways. And except for radius of the airways, all other variables are relatively constant. Thus, airway resistance can undergo physiologic alteration by changes in the radius of the airway bronchus. So the importance of compliance. Lung compliance is inversely proportional to elastance, which we said 2 slides ago. This elastic resistance is both due to elastic property of lung tissue, or parenchyma, and the surface elastic force. Any changes occurring to these forces can lead to changes in compliance, and compliance determines 65% of work of breathing in patients. If a lung has low compliance, it requires more work from breathing muscles to inflate the lung. Next, it's important to consider factors that affect lung compliance. So starting with elastic properties of the lung tissue, and this results from collagen and elastin fibers meshed inside the lung parenchyma. When the lung expands, these fibers elongate and exert more of an elastic force similar to that of a rubber band. Thus, the flexibility of these fibers determines the compliance of the lung. The next factor that affects compliance is the surface tension elastic force, and this is a concept affecting lung compliance, and its elastic property in relation to surface tension of the alveolar lining. Next, surfactant. Surfactant is a surface active agent in fluid secreted by type 2 alveolar epithelial cells lining the alveoli. It's a complex molecule containing phospholipids, surfactant apoproteins, calcium ions, and they reduce the surface tension. It's important here to draw knowledge from chemistry and physics from the spring semester, and consider that when you're measuring alveolar pressure using surface tension exerted by the lining of the fluid, this is based on the law of Laplace, which states that pressure is equal to 2 times the surface tension divided by radius. Next, moving on to lung volumes. So specific compliance is equal to compliance divided by FRC. And I would advise you to go back a couple of slides and look at that chart with the inspiratory and expiratory flow volume loop, and realize that when there is increased compliance, it takes less force to inflate the lung and vice versa. Next, the last factor affecting compliance of the lung is age. This factor minimally influences compliance, but pulmonary compliance increases with age because of structural changes in the elastin fibers. Okay, so now focusing on static lung compliance. This is a change in lung volume per unit of pressure change within the lung when air is not moving. You calculate it based on tidal volume divided by peak plateau pressure minus PEEP. And that's why I wanted to mention peak and plateau pressures. So the plateau pressure, again, is the pressure observed during momentary exhalation delay when the lungs are at end expiration. An inspiratory pause is required on a ventilator to observe the plateau pressure. So when we're thinking about static lung compliance, this is going to reflect compliance of the lung tissue and the chest wall alone. And its static lung compliance is decreased by conditions that make the lung difficult to inflate. So think about fibrosis, obesity, vascular engorgement, edema, ARDS, and external compression. External compression is something that might be new to your clinical assessment because of we're working together with surgeons, and there are times where they're compressing on the thoracic cavity that can impact your ability to ventilate your patient. So you need to consider what's going on the other side of the drape, as well as the patient's baseline pulmonary status. Next, thinking about dynamic lung compliance, this is a change in lung volume per unit of pressure change within the lung during air movement. You calculate it based on tidal volume divided by peak inspiratory pressure minus PEEP. And again, it's measured by pressure during gas flow and reflects the compliance of the chest wall, lung tissue in combination with airway resistance. And dynamic lung compliance is going to be decreased by airway obstruction, including bronchospasm, secretions, or a kinked endotracheal tube. So here's a summary slide. So static compliance, again, is tidal volume divided by peak plateau pressure minus PEEP. And normally this is 60 to 100 mLs per centimeter of water in an adult patient. And then dynamic compliance, so this is measured during air movement. And you calculate it, tidal volume divided by peak inspiratory pressure minus PEEP. So next, thinking about lung pressures, and the lung pressure title of the slide is a link to a video that I would encourage you to go look at. So pleural pressure is the pressure that exists within the pleural space outside the lung between the visceral pleura of the lung and the parietal pleura of the inner chest wall. Pleural pressure is influenced secondary by extensive lymphatic network that is continuously pulling fluid and proteins out of the lungs, thus augmenting negative pressure within the intrapleural space. Essentially, the negative pressure within the pleural space acts like a suction cup to keep the lungs inflated. In the upright position, intrapleural pressure is more negative at the apex of the lung as compared to the base of the lung. So I'll say that one more time. In the upright or standing position, intrapleural pressure is more negative at the apex of the lung as compared to the base. This is because the weight of the lung tissue, blood, lymphatic drainage, and other intrapulmonary and chest contents push the pleural space within a positive pressure, making the pressure within the intrapleural space less negative as it travels towards the lung base. During inspiration, the chest wall expands, creating a greater outward force and resulting in a decreased or more negative intrapleural space. So I want to make note of this here. The intrapleural space is a negative number. So if you're going to be becoming more, or if that number is going to decrease, you're going to be becoming more negative. Conversely, during expiration, the chest wall forces retract inward, resulting in an increased or less negative intrapleural pressure. It's important to note that pressure within the intrapleural space during the respiratory cycle is always negative or subatmospheric, but can become zero or equal to atmospheric pressure if the chest wall and parietal pleura are breached, such as that during a pneumothorax. The average pleural pressure is negative 756 millimeters of mercury. Next, moving on to intraalveolar pressure. This is the pressure applied to the inside of the alveoli, and it's also known as intrapulmonary pressure. Between each inspiratory and expiratory cycle, there is no air movement, and as long as the airways are open, and the intraalveolar pressure should be the same as atmospheric pressure, so roughly 760 millimeters of mercury. This resting intraalveolar pressure, where there's no gas flow, is referred to as zero. Since atmospheric pressure is relatively constant, pressure in the lungs must be higher or lower than atmospheric pressure for air to flow between the atmosphere and the alveoli. So I'll say that one more time because I think it's really important. Since atmospheric pressure is relatively constant, pressure in the lungs must be higher or lower than that of atmospheric pressure for air to flow between the atmosphere and the alveoli. As the diaphragm contracts during inspiration, intraalveolar pressure decreases or becomes more negative, causing air to flow from an area of high pressure, such as the atmosphere, to an area of low pressure, such as the alveoli, resulting in an increased intrapulmonary volume. This physiology works based on Boyle's law, which I've listed here for you, and it essentially states as volume increases, the pressure in the lung will decrease. Lastly, we're going to look at transpulmonary pressure, and this is the difference between intraalveolar pressure and intrapleural pressure. This pressure that's delivered to the lung tissue itself is independent of the chest wall and abdominal forces. In essence, transpulmonary pressure is the net pressure that distends the lungs during contraction of the inspiratory muscles or during positive pressure ventilation. The higher the transpulmonary pressure is, the more distended the lung. The transpulmonary pressure is always positive in a normal, spontaneously breathing individual whose physiology is unaltered. This is due to the negative intrapleural pressure in the following equation, which again is transpulmonary pressure or transmural pressure is equal to intraalveolar pressure minus intrapleural pressure. This concept can be really challenging, and again, I would direct you to the YouTube video that helps, gives you a couple visual graphics and walks you through this step by step. Moving on to oxygenation. Before we get into the physiology of oxygenation, I think it's really important to highlight how human metabolism is going to drive that oxygen demand and how it impacts delivery. So the breakdown of carbohydrates, glucose and glycogen, involves both anaerobic and aerobic biochemistry, and energy is contained within the molecular bonds of glucose and is released during their breakdown, which is the process we know as glycolysis. So let's look more specifically at aerobic metabolism and anaerobic metabolism. Aerobic metabolism is a chemical process in which oxygen is used to make energy. Mitochondria continue to remove hydrogen and electrons from pyruvate or fatty acids via a metabolic pathway we know as the Krebs cycle, which we learned about in high school and in undergraduate chemistry classes. Oxygen attracts electrons as part of the electron transport chain that's located within the inner mitochondrial membranes. And remember from basic biology class, the mitochondria is the powerhouse or where a cell derives energy. Through aerobic metabolism, the end products are generation of ATP, which we use for energy, plus heat. And during aerobic metabolism, oxygen delivery is meeting metabolic demands. Compared to anaerobic metabolism, this is when metabolism exceeds oxygen delivery. When anaerobic, you have anaerobic removal of hydrogen and electrons from glucose and glycogen. This is matched to the rate of aerobic metabolism. Then pyruvate is the end product. Sometimes when we exercise too heavily or we're really sick, rapid substrate level phosphorylation proceeds at a rate that exceeds aerobic metabolism. Instead of being carried toward the site of aerobic metabolism, the rapidly removed hydrogen ions and electrons are accepted by the pyruvate to become lactate. Lactate appearance is a natural part of an accelerated anaerobic metabolism where substrate level phosphorylation provides a significant amount of ATP and heat because of energy expenditure. The more intense the metabolic demand, the faster the rate of ATP hydrolysis is required, and the more glucose and glycogen are preferred to fuel or produce ATP. And again, pyruvate during anaerobic metabolism is converted into lactic acid, which is why we draw lactic acid levels on our patients in the ICU. Same thing applies during patients having surgery. We know there's going to be a stimulus that's going to cause a stress response, which could lead to lactic acid production if we're not able to meet those metabolic demands for our patients. So as an overview, again, human metabolism aerobic metabolism versus anaerobic metabolism. During aerobic metabolism, our oxygen delivery is able to meet metabolic demands, and then during anaerobic metabolism, metabolism is going to exceed oxygen delivery, and then pyruvate is converted into lactic acid. It's important to consider gas diffusion and the relationship to partial pressure. So the rate of diffusion is directly proportional to the partial pressure of a gas. So for an example, the higher the partial pressure of a gas, the more readily that gas is to diffuse across the membrane, and the lower the partial pressure of a gas, the less likely it is to diffuse across a membrane. I think it's important to apply Dalton's law here, which states when you're considering a combination of gases, the total pressure of that mixture is the same as the sum of the partial pressures of each individual gas present in that mixture. Thinking about oxygen, the partial pressure of oxygen depends mainly on atmospheric barometric pressure and its fractional concentration. Geographical altitude is an important factor affecting barometric pressure because as altitude increases, the amount of gas molecules in the air decreases, so air becomes less dense at sea level. And here is an example of gases contained in the atmosphere. So it's 78% nitrogen, 21% oxygen, which we know, 0.9% argon, and then a smaller fraction is carbon dioxide and other gases. Gas in a solution. So there's two determinants for gases to move from being in a gas state to a liquid or solution state. The determinants are the concentration of the gas and a solubility coefficient. And Henry's law helps define this. So for a constant temperature, the amount of gas dissolved in a liquid is directly proportional to the partial pressure of that gas. And solubility coefficients are listed here for you for oxygen, carbon dioxide mainly, is why I wanted to include this chart. So now when we're thinking about oxygen delivery and the movement from oxygen into the atmosphere all the way down into our alveoli, into the arterioles, and then delivery out to our tissues. So PiO2 is the pressure of inspired oxygen. And you calculate that considering atmospheric pressure at sea level, which is 760 millimeters of mercury, minus 47 millimeters of mercury, which is the saturation of water vapor, times 0.21%, which is the percentage of oxygen in the air, and you're going to get roughly 150 millimeters of mercury of pressure. Water vapor dilutes all other gases that are inspired, and humidification of the air dilutes oxygen's partial pressure at sea level. The partial pressure that water molecules exert to escape through surface area at normal body temperature at a normal body temperature, which is 37 degrees Celsius, is 47 millimeters of mercury. The vapor pressure of water depends entirely on the temperature of the water pressure. So why? The greater the temperature, the greater the kinetic activity of molecules, and therefore the greater the likelihood that water molecules will escape from the surface of the water into the gas phase. So key takeaway here, you need to be considering atmospheric pressure, subtracting the impact of water vapor on that atmospheric pressure, times the concentration of oxygen in the air, and that's going to get you a partial pressure of 150 millimeters of mercury. Moving on, looking at oxygen in the alveoli, and that's calculated by this equation listed here. So we defined PiO2 in our last slide, and you're going to subtract the amount of CO2 in the arterioles times 1 divided by RQ, which is the respiratory quotient, and this defines the relationship between oxygen consumption and CO2 production, and that's going to equal approximately 102 millimeters of mercury. So the pressure of oxygen in the alveoli is roughly 102 millimeters of mercury, with definitions listed here. I found this slide to be really helpful thinking about the oxygen cascade going from atmospheric pressure and then all the way down to the mitochondrial inner cell. So you can see that as you have dry atmospheric air, the concentration of oxygen is going to fall as it goes through our respiratory tract, into our lungs, into our blood, and then finally reaching terminal cells used for metabolism. Again, defining the respiratory quotient, the definition is the relationship between O2 consumption and CO2 production. VO2 is the abbreviation used for oxygen consumption in the body, and VCO2 is used for carbon dioxide production. In the alveoli, oxygen is exchanged for carbon dioxide, and that ratio is typically 1.25 to 1. When thinking about oxygen and carbon dioxide exchange, you need to consider diffusion. And oxygen readily crosses the alveoli into the blood because of the high partial pressure gradient and a thin alveolar capillary membrane. And again, PAO2 is the oxygen concentration in the alveoli, and then PaO2 is oxygen concentration in the arterioles. Oxygen delivery. So you have to think about not just diffusion, but how does that oxygen get delivered to the rest of the body? And that's by our heart pumping or cardiac output, right? So oxygen delivery, the abbreviation is DO equals cardiac output times the concentration of oxygen in our blood. This is a really important equation to remember, and we're going to kind of break it down in the next couple of slides. Next, moving on to oxygen in our blood. We know that 98% of oxygen in our blood is attached to a hemoglobin molecule, and the other 2% is dissolved in the plasma. So let's look at this equation, and we'll break down each component. I think it's really important that you memorize this equation and know it not only for practice, but for standardized testing. So DO is oxygen delivery, that's how we represent that, is equal to cardiac output, so heart rate times stroke volume is cardiac output, that's how you calculate that, times, and then the amount in parentheses is the amount of oxygen attached to a hemoglobin molecule. So 1.34 milliliters per gram is the maximum amount of oxygen carrying capacity of the blood, times the patient's hemoglobin, times the percentage of hemoglobin saturated with oxygen, and this is represented as a percentage, plus the amount of oxygen dissolved in the plasma, which you're going to look at the PaO2, or the partial pressure of oxygen, times the standard, which is a solubility constant for oxygen at 37 degrees Celsius, which is 0.003. So a clinical question you're often going to face is, how well are we oxygenating our patients? And you've already had to deal with this as a bedside nurse, right? Particularly in the ICU, caring for critically ill patients. Same thing applies to anesthesia. So something that, or a tool that can help us decide whether we are oxygenating well or not, is considering an AA gradient. And this is the difference between the oxygen concentration in the alveoli compared to the arterial system. It's calculated here and can be utilized to identify different causes of hypoxemia. There can be a normal gradient or an increased gradient. A normal gradient can be present in hypoventilation. Patients can exhibit hypoventilation for a variety of reasons, and some of those include CNS depression, neuromuscular diseases, poor chest elasticity, patients with vertebral fractures, and many others. I think this is important to highlight here, that the majority of patients we're caring for, whether it's sedation or general anesthesia, are going to have hypoventilation. Patients with poor ventilation lack oxygen tension through their arterial system in addition to their respiratory system. Since both the capital A, which is the partial pressure of oxygen in the alveoli, and the little a, which is the partial pressure in their arterioles, decrease in concert, so they're both decreased in a hypoventilating patient, the gradient between the two will remain within normal limits. Thus, patients with hypoxemia due to hypoventilation will actually have an AA gradient within normal limits. Compared to patients with pneumonia, they have a physical barrier within the alveoli limiting the diffusion of oxygen into the capillaries. However, these patients can ventilate well or okay, which will result in well-oxygenated respiratory tract with poor diffusion of oxygen across the alveolar capillary membrane. Thus, lower oxygen levels will be in the arterial blood. These patients with hypoxemia due to pneumonia have an inappropriately elevated AA gradient. So I think it's important to take some time and dissect this and realize it can be really impactful to answer this question. The other way we can assess if we're oxygenating well is to take your FiO2, multiply it by 5, and that should be roughly your PaO2. So for example, if you're on 50% FiO2, multiply that by 5. If you were to draw an arterial blood gas, your PaO2 should be around 250. When we're considering oxygenation, we need to review the oxygen hemoglobin dissociation curve. So the standard curve is in the middle, and then if you have a right shift, this occurs with an increased PaCO2, increased hydrogens or acidotic state. You have an increased 2,3-DPG, or an increased temperature. And again, a rightward shift, the oxygen molecule is going to be released from the hemoglobin to try to disperse into our tissues. So the way I remember this is a right shift, oxygen molecule is released from the hemoglobin molecule. And again, that occurs with increased PaCO2, increased hydrogen ions, such as during acidosis, increased 2,3-DPG or increased temperature. And then a leftward shift occurs in the opposite of all of those things. So a decreased PaCO2, decreased hydrogen ions or alkalosis, decreased 2,3-DPG, or decreased in temperature or fetal hemoglobin. And I remember this, a left shift, the oxygen molecules want to latch to the hemoglobin molecule. So left shift, the oxygen latches to the hemoglobin. Hypoxemia. So this is low arterial oxygen tension and harms by impeding oxygen transfer from blood to cells. The most common mechanism of hypoxemia is ventilation perfusion inequality, and this is common due to acute respiratory failure, chronic lung diseases, and general anesthesia. So we're going to potentially face patients who are hypoxemic every day that you're at work. Of note, increasing oxygen content, for example, by transfusion, does not cure hypoxemia. Induction of general anesthesia, you're going to have a decrease in functional residual capacity, which can predispose patients to atelectasis. PEEP, or positive end expiratory pressure, returns lung volumes, prevents atelectasis, and can help you avoid hypoxemia. So succession of physiologic events decreasing PaO2 during general anesthesia. This occurs shortly after induction, and the resting volume of the lung, or the FRC, which is the reserve for oxygen, can decrease by an average of 500 mLs in an adult. Added to the volume lost by going from a standing position to a supine position, the FRC is then further reduced by approximately 3 liters to just more than 2 liters. So close to residual volume. And again, I would encourage you to go back to that slide and look at that slide as you're listening to this portion of the lecture. The main cause of hypoxemia in patients under general anesthesia is loss of muscle tone with a consequent cephalad displacement of the diaphragm. Next, moving on to ventilation. So ventilation, you have to think about minute ventilation, which is tidal volume times respiratory rate. Ventilation is driven by metabolic demand, and in an adult patient, a normal tidal volume is roughly 500 mLs. Respiratory rate is 12 to 16 breaths per minute. So if you multiply tidal volume times respiratory rate, it's roughly 8 liters per minute of minute ventilation. You have to consider dead space. Dead space is approximately 30% of the tidal volume, and as we defined in an earlier lecture, dead space is not partaking in gas exchange, or areas in the respiratory system or tract that are not partaking in gas exchange. And in the adult patient, it's roughly 100 to 150 mLs. Next, looking at alveolar ventilation, you have to take a normal tidal volume, subtract dead space times the respiratory rate, and that's going to give you approximately 5 liters per minute of minute ventilation for your patients. During spontaneous ventilation, the ratio of alveolar ventilation to dead space is approximately 2 to 1. The alveolar to dead space ventilation ratio during positive pressure ventilation is 1 to 1. Thus, minute ventilation during mechanical ventilatory support must be greater than that during spontaneous ventilation to achieve the same PaCO2. So I'm going to say that sentence one more time because I think it's really important that you understand this concept. So when a patient is awake and they are spontaneously breathing, the ratio of alveolar ventilation to dead space is 2 to 1. Compared to a patient who is asleep receiving positive pressure ventilation, that ratio of alveolar ventilation to dead space is 1 to 1. So you're going to need to increase your patient's minute ventilation to compensate for that decrease in ratio and to achieve a normal PaCO2. So, where are the respiratory centers in the brain? So, the medulla oblongata contains the most basic ventilatory control centers in the brain. Specific medullary areas are primarily active during inspiration or during expiration, with many neural inspiratory or expiratory interconnections. So, the inspiratory centers that reside in the dorsal respiratory group are located in the dorsal medullary reticular formation. The DRG is a source of elementary ventilatory rhythmicity and serves as a pacemaker for the respiratory system. Whereas resting lung volumes occurs at end expiration, the electrical activity of the ventilatory centers is at rest at end inspiration. The rhythmic activity of the DRG persists even when all incoming peripheral and interconnecting nerves are sectioned or blocked completely. Isolating the DRG in this manner results in ataxic gasping ventilation with frequent maximum inspiratory efforts, which is known as apneustic breathing. So thinking about the expiratory center, the ventral respiratory group is located in the ventral medullary reticular formation and serves as the expiratory coordinating center. The inspiratory and expiratory neurons function by a system of reciprocal innervation or negative feedback. So this is a negative feedback loop. When the DRG creates an impulse to inspire, inspiration occurs and the DRG impulse is quenched by a reciprocating VRG impulse. This VRG transmission prohibits further use of inspiratory muscles, thus allowing passive expiration to occur. The pontine centers of the brain process the information that originates in the medulla. The apneustic center is located in the middle or lower pons, and with activation, this center sends impulses to the DRG neurons to sustain inspiration. Electrical stimulation of this area results in an inspiratory spasm. Next, looking at pneumotaxic ventilatory center, this is in the rostral pons, and a simple transection through the brainstem that isolates this portion of the pons from the upper brainstem decreases ventilatory rate and increases tidal volume. The primary function of the pneumotaxic center is limited to depth of inspiration. Moving on to central chemoreceptors in the brain, the chemosensitive areas of the brainstem are in the infralateral aspects of the medulla near the origin of the glossopharyngeal and vagus nerves. The area just beneath the surface of the ventral medulla is exquisitely sensitive to extracellular fluid hydrogen concentration. And although this central response is the major regulator of breathing, carbon dioxide has little direct stimulating effect on these chemosensitive areas. These receptors are primarily sensitive to changes in hydrogen concentration. Carbon dioxide has a potent but indirect effect by reacting with water to form carbonic acid, which will eventually dissociate into hydrogen and bicarb ions. So the equation is water plus carbon dioxide is going to be equal to carbonic acid, which eventually will dissociate into hydrogen and then bicarb ions. An acute increase in PaCO2 is more of a potent ventilatory stimulus than an acute increase in arterial hydrogen ion concentration from a metabolic source. Carbon dioxide, but not hydrogen ions, readily passes through the blood-brain barrier, although local buffering systems in the arterial blood and body fluids immediately neutralizes hydrogen ions. The CSF has minimal buffering capacity. So it's really important. I'm going to repeat that again. This cerebral spinal fluid has minimal buffering capacity. Thus, once carbon dioxide crosses into the CSF, hydrogen ions are created and trapped in the CSF, resulting in a concentration considerably greater than that found in relation to the blood. So you're comparing the concentration of hydrogen ions in cerebral spinal fluid compared to the blood. And again, CSF has minimal buffering capacity. Therefore, there's going to be a greater gradient or an increased gradient of hydrogen ions in the CSF compared to that of the blood. Because carbon dioxide crosses the blood-brain barrier readily, again, the PCO2 values in the CSF, cerebral tissue, and jugular venous blood rise quickly to the same degree as PaCO2, although the central values are about 10 millimeters of mercury higher than those measured in arterial blood. The ventilatory response to changes in PaCO2 are going to be increased tidal volume and increased respiratory rate, is rapid, and this peaks within 1 to 2 minutes after an acute change in PaCO2. With persistent levels of carbon dioxide stimulation, however, the resultant increase in ventilation declines over a period of several hours. This is probably the result of bicarb ions that are actively transported from the blood into the CSF through the arachnoid villi that increase CSF pH towards a normal range. Moving on to peripheral chemoreceptors. So these receptors predominantly respond to a lack of oxygen, and they're located in the carotid and aortic bodies. So peripheral chemoreceptors in the carotid bodies are located at the bifurcation of the common carotid artery and have predominantly ventilatory effects. Compared to the aortic bodies, or the peripheral chemoreceptors located in the aortic bodies, they're scattered around the aortic arch and its branches and have predominantly circulatory effects. So carotid bodies have predominantly ventilatory effects, and then the aortic bodies predominantly circulatory effects. Both carotid and aortic bodies are stimulated by a decrease in PaO2, and when PaO2 falls less than 100 millimeters of mercury, neural activity from the receptors begins to increase. However, it's not until a PaO2 reaches 60 to 65 millimeters of mercury that neural activity increases sufficiently to substantially augment minute ventilation. Patients who depend on hypoxic ventilatory drive, so think about COPD patients, have PaO2 values in the mid-60s. These patients' PaO2 values, when they exceed 60 to 65, ventilatory drive diminishes and PaO2 falls until ventilation is again stimulated by arterial hypoxemia. This can be really challenging when you're trying to emerge from general anesthesia and someone has COPD and their drive to breathe is coming from hypoxia. So this kind of explains why. Moving on to the Herring-Brewer reflex, this is when a patient is lightly anesthetized, spontaneously breathing animals would cease or decrease ventilatory effort during sustained lung distension. So this is actually a protective mechanism. And this picture here is from Nagelhout. So you can see on the left the stimulus lung inflation. The reflex is the Herring-Brewer inflation reflex. The receptor is listed here, the stretch muscles within stretch receptors within smooth muscle. The afferent pathway is the vagus nerve, and in the effects you have cessation of inspiratory effort, apnea, or decreased breathing frequency. Conversely, during lung deflation, the Herring-Brewer reflex or deflation reflex is also active. Receptor is possibly J receptors. Again, the afferent pathway is the vagus nerve, and the effects you have respiratory hyperapnea. So I included this slide because I think it's really important for clinical practice. So first I want to draw your attention to the x-axis where it's PaCO2 and it's measured in millimeters of mercury, and then the y-axis is your alveolar ventilation in liters per minute. So starting with the normal awake patient, so it's the second line in the middle, you can see that normally as our PaCO2 increases, our alveolar ventilation will also increase. And that line is shifted to the right slightly when we're sleeping. So it requires a little bit higher of a PaCO2 to increase minute ventilation. Our anesthetic agents, if you're only thinking about volatile anesthetic agents, are going to further shift that PaCO2 response to the right, meaning it's going to take a higher PaCO2 to stimulate respiratory effort or alveolar ventilation. And then finally, you see all the way down to the right, high-dose fentanyl. It requires a significantly higher PaCO2 to increase alveolar ventilation. And we know this, particularly when patients are narcotized or over-narcotized. They take really large tidal volumes and their breathing becomes a little less frequent. So this, I think, I would keep, particularly when you're considering titration of medications and how to titrate not only your gas but opioid medicines. So this is just another picture of what I had described previously, except a little less specific. So agents that we use that are going to shift this PaCO2 line to the right are going to include opiates, anesthetic vapors, hypnotics. So if patients get pre-medication with Versed, this can also contribute to a rightward shift. So I included this slide to kind of summarize all of the aspects of ventilation that we've talked about before. The control centers are listed here, and then you can see in higher cortical areas, there's volunteer control of our respiratory status. Peripheral chemoreceptors are listed in the lower left-hand side. And then you can see innervation in the lower right-hand side, the vagus nerves, and the stretch receptors we discussed. And lastly, we'll talk about this equation in the upper right-hand corner. And this is really important when thinking about acid-base balance in our blood and how it impacts our ventilatory drive. So as we're undergoing metabolism, there's CO2 production, which is going to combine with water to form carbonic acid, which then is going to dissociate into hydrogen and bicarb to create that buffer. I think it's really important, and a clinical application that I always think about is when you're treating an acidotic patient, this equation can actually go in reverse as well. So if you are wanting to give bicarb to an acidotic patient, you need to make sure that that patient is ventilating well in order to be able to blow off that carbon dioxide. If your patient's not ventilating well, they're going to just retain that bicarb and potentially retain that hydrogen ion, and you're going to exacerbate an acidosis if you're not able to breathe off that CO2. We can talk more about this in class. So hyperventilation, there's typically three etiologies. First, arterial hypoxemia. Second, metabolic acidemia. And third, there's central etiology, such as intracranial hypertension, hepatic cirrhosis, anxiety, and then often what impacts our practice is pharmacologic agents. So I don't feel like a pulmonary physiology lecture would be complete without mentioning atelectasis because it impacts our job often. So atelectasis, the cause or mechanism can be due to three processes. So first, or categories, if you will. First is compression of lung tissue, which is known as compressive atelectasis. Second is absorptive or alveolar air, or resorptive atelectasis. And then third is impaired pulmonary surfactant production or function, which is known as adhesive atelectasis. Atelectasis is one of the most common respiratory complications in the perioperative period, and it may contribute to significant morbidity and mortality, including the development of pneumonia and acute respiratory failure. So starting with compression atelectasis, this is secondary to increased pressure exerted on the lung, causing the alveoli to collapse. In other words, there's a decrease in transmural pressure gradient. Remember, transmural pressure gradient is alveolar pressure minus intrapleural pressure across the alveolus, resulting in alveolar collapse. In an awake, spontaneously ventilating patient, caught at exertion of the diaphragm during contraction causes subsequent decrease in intrapleural pressure and alveolar pressure. The decrease in pressure allows for passive movement into the lungs. This process is inhibited by general anesthesia due to the diaphragm relaxing. It's more common in patients who recently underwent general anesthesia, with the incidence being as high as 90%, so it affects the majority of our patients. Research has shown that atelectasis appears in dependent regions of both lungs within 5 minutes of induction of anesthesia. So you can see why we want to optimize our chance for caring for our patients. You want to be filling your functional residual capacity with oxygen before instrumenting the airway. Also, obese and or pregnant patients are more likely to develop atelectasis due to cephalad displacement of the diaphragm. And I have the image here. You can see the consolidation in the right upper lobe of the lung. So the pathophysiology of atelectasis, there's increased risk of developing it in the perioperative period with the administration of general anesthesia, use of muscle relaxants, obesity, pregnancy, inadequate pain control, thoracic or cardiopulmonary procedures, and then high inspiratory oxygen concentration during induction and maintenance of general anesthesia can also contribute to absorptive atelectasis. Studies have demonstrated that up to 15 to 20% of the lung at its base collapses during uneventful anesthesia before any surgical intervention. Atelectasis is seen when general anesthesia, regardless of whether or not muscle paralysis is used. Obese patients have increased incidence of atelectasis due to the decrease in FRC, or functional residual capacity, and a decreased compliance. Atelectasis development in pregnant patients is by the same mechanism. Of note, ketamine, when used as a sole agent, which is actually pretty rare in anesthesia, is the only anesthetic agent that does not increase the risk of developing atelectasis. So how do we prevent it? One study showed that intraoperative alveolar recruitment with a vital capacity maneuver, again, go back to your lung vital capacities or the different capacities chart, followed by PEEP of 10 centimeters of water is effective at preventing lung atelectasis in morbidly obese patients. This also correlated with better oxygenation, shorter PACU stay, and fewer pulmonary complications. So you can see that this needs to really be on your mind when you're caring for your patients. So we prevent it by avoiding general anesthesia when possible, early mobilization, adequate pain control, and then minimizing parenteral opioids. Often in anesthesia, you'll hear us talk about multimodal analgesia. So that's leveraging other pain medicines that target receptors that aren't opioids. So think about Tylenol, NSAIDs. There's research, particularly now with enhanced recovery after surgery protocols, to include lidocaine, scopolamine patches. These are all things you should be thinking about. So when general anesthesia is required, it's recommended that you use continuous positive airway pressure, even with supraglottic airways. The lowest possible FiO2 during induction and maintenance. This is controversial. I still think pre-oxygenating your patient is the traditional teaching during induction. So maintenance, you definitely don't want to run your patients on 100% FiO2 if they're going to tolerate less. PEEP, lung recruitment maneuvers, and then lower tidal volumes. So treatment of atelectasis. Most atelectasis appears during general anesthesia, leads to transient lung dysfunction that resolves within 24 hours. It's important to think about changing position from supine to upright. That's going to increase your FRC and decrease atelectasis. You want to encourage patients to take deep breaths, early ambulation, incentive spirometry, use of acapella device, chest PT, tracheal suctioning with patients who are intubated, and then again, positive pressure ventilation. So next, moving on to perfusion. Starting with lung zones, which are traditionally referenced as the west zones of the lung. So looking at the image here, you see the apex of the lung is at the top, and then the base of the lung is listed at the bottom. On the left is the pulmonary artery, on the right is the pulmonary vein. And remember, pulmonary arteries are going to be carrying deoxygenated blood to the lungs, where they'll be oxygenated, or oxygen will be exchanged for carbon dioxide in the alveolar capillary membrane, and then the pulmonary veins are going to return that oxygenated blood to the left side of the heart and then out to the body. So let's start with abbreviations. P capital A is the partial pressure in the alveoli, P little a is the pressure in the pulmonary arteries, and then PV is the pressure in pulmonary veins. So in the normal upright lung, a greater portion of blood flow is distributed to the dependent regions because of the effects of hydrostatic pressure and greater distension of the dependent pulmonary vessels. Likewise, differences in compliance of the ventilating tissue will also result in a general increase in proportion of ventilation from non-dependent to dependent areas of the lung. Despite the fact that gravitational model explaining ventilation perfusion distribution between zones, which again was described by West starting in 1964, has not been completely confirmed by both animal and human studies, it does serve as a useful model for considering the relationship between ventilation and perfusion. More specifically, the conditions under which intraalveolar pressure may impede vascular flow. So in this model, regions of the lung are divided into zones according to relative intravascular and intraalveolar pressure. So you're considering, again, the relative relationship between intravascular and intraalveolar pressure. Starting with zone 1, this exists in parts of the lung where alveoli exist at a greater resting volume. Alveolar pressures can exceed pulmonary artery pressure so that perfusion is impeded. It represents alveolar dead space because the region is ventilated but not perfused. And normally, zone 1 either does not exist or exists only in very small margin of the lung area around the apical border during spontaneous ventilation. However, the use of PEEP or high airway pressures during positive pressure and or mechanical ventilation can create or expand this zone. Next, moving on to zone 2. I'll draw your attention to the equation under zone 2 where you see P little a, which is the pulmonary arteries. The pressure is greater than the pressure in the alveolus, which is greater than the pulmonary veins. So zone 2 is considered the intermediate zone, which consists of a variable relationship between vascular and alveolar pressure. A point is described in zone 2 along the continuum of decreasing intraalveolar pressure where arterial pressure exceeds alveolar pressure. Below that point, flow is solely dependent upon arterial flow and unrelated to alveolar or venous pressure. The zone 2 relationship is not static, but fluctuation in alveolar pressure related to respiration can variably occlude capillary flow. Next, moving on to zone 3. The dependent portion of the lung where both pulmonary, arterial, and venous pressures exceed alveolar pressure is known as zone 3. Thus, there is no obstruction to blood flow. The tip of the pulmonary artery catheter should be placed within this zone to ensure continuous communication with the left side of the heart. Alveoli in this zone rest at lower volume than in zones 1 and 2, and so have a greater compliance with the ability to better expand to ideally match ventilation to perfusion within the lung. There has been a theoretical zone 4 developed, but we won't necessarily cover that in this lecture. So this is another slide. The title of the slide is a hyperlink to a YouTube video to further explain ventilation perfusion ratio and the west zones of the lung. Next, moving on to VQ distribution. This is measured by multiple inert gas elimination technique, and this is based on the infusion of a mixture of 6 dissolved inert gases with a known range of solubility, and then measuring their concentrations in arterial blood and expired gas. This technique is dependent on the 3-compartment model. The 3 compartments include first, an ideal compartment, second, a non-ventilated compartment, and then third, a non-perfused compartment or dead space. So when considering VQ mismatch, you see in the middle here, this is a normal ventilation to perfusion is matched well, and that typically is going to equate to 0.8. Next, moving on to dead space ventilation. So this is where VQ ratio is undefined or infinity, because you're going to have well ventilated alveoli. However, you have no perfusion going through the alveolar capillary membrane to participate in exchange. This can occur, you see there, with a segmental pulmonary embolism or a massive PE. Last, we're going to go all the way to the left. You have something called an intrapulmonary shunt. And this is essentially where you have the alveolus full of liquid or unable to participate in gas exchange, but it's well perfused. This can occur in pulmonary edema or ARDS, pneumonia, and atelectasis that we talked about earlier, and the VQ ratio for this is 0. Again, here's another YouTube video explaining that if you need further explanation. So diving a little bit deeper into dead space. Again, the VQ ratio is undefined or infinity. And then there's 3 types of dead space. There's anatomic dead space. This is the volume of air located in the respiratory segments that are responsible for conducting air but do not take part in the process of gas exchange. 2, there's physiologic dead space, which is comprised of anatomic plus alveolar dead space. And then third is apparatus dead space. So any device added past the Y piece on your circuit is going to add to dead space, and airway devices are included in this. Increases in dead space ventilation primarily affect CO2 elimination with minimal influence on arterial oxygenation. So dead space ventilation. In theory, if you have increased dead space, you're going to have increased minute ventilation to compensate and have adequate PaCO2. States with an increased dead space include bronchiectasis, which is defined as a chronic lung disease characterized by persistent and lifelong widening of the bronchial airways and weakening of the function mucociliary transport mechanism owing to repeated infection, contributing to bacterial invasion and mucus pooling throughout the bronchial tree. Another cause of increased dead space is obstructive lung diseases such as asthma, COPD, and emphysema, and then anesthesia can also contribute to dead space. Moving on to physiologic shunting, remember the ratio is for ventilation to perfusion is equivalent to 0. This shunting is primarily going to affect arterial oxygenation. Remember, shunting is when your alveolus is not ventilated, but you actually have perfusion passing through. Again, no gas exchange or minimal gas exchange in the alveolar capillary membrane. For the sake of being comprehensive, I thought it was important to mention hypoxic pulmonary vasoconstriction, which is actually a protective mechanism our body has to try to regulate regional ventilation and perfusion. Hypoxic pulmonary vasoconstriction is stimulated by alveolar hypoxia, and it ultimately is going to severely decrease blood flow. The onset is within seconds of exposure to hypoxia, and it reaches maximal intensity within minutes. Intrapulmonary arteries constrict in response to alveolar hypoxia, diverting blood to the better oxygenated lung segments. thereby optimizing ventilation perfusion matching and systemic oxygen delivery. More specifically, there's a mitochondrial sensor dynamically changing reactive oxygen species and redox couples in pulmonary artery smooth muscle cells. This inhibits potassium channels, depolarizes the pulmonary artery smooth muscle cells, activates voltage-gated calcium channels, and increases cytosolic calcium, causing vasoconstriction. Sustained hypoxia activates Rho kinase, reinforcing vasoconstriction and hypoxia-inducible factor, or HIF-1A, leading to adverse pulmonary vascular remodeling and pulmonary hypertension. In the non-ventilated fetal lung, HPV, or hypoxic pulmonary vasoconstriction, diverts blood to systemic vasculature, so that can be really helpful intrautero. Hypoxic pulmonary vasoconstriction also optimizes PO2 in patients with atelectasis, pneumonia, COPD, and asthma by reducing the VQ mismatch and shunting. During pneumonia or atelectasis, hypoxic pulmonary vasoconstriction optimizes systemic oxygen delivery by reducing perfusion of the hypoxic segment. The HPV rapidly reverses on relief of atelectasis or on resolution of pneumonia. Hypoxic pulmonary vasoconstriction is critical in single lung anesthesia for patients undergoing thoracic surgery such as lung tumor wedge resections. Hypoxic pulmonary vasoconstriction within the non-ventilated lung reduces perfusion by minimizing shunting that would otherwise lead to intraoperative systemic hypoxemia and excessive bleeding in the operative field. This slide essentially details what we just discussed in the previous slide. However, I wanted to include it if you're a visual learner. In the comment section of this slide, you can see the caption for this, each reaction that's happening. What factors are going to augment hypoxic pulmonary vasoconstriction? First, catecholamines, and this is due to higher doses because of alpha-1 stimulation. Pulmonary vessels contain alpha-1 and beta-2 adrenoreceptors and dopaminergic receptors, and animal studies of adrenaline, dopamine, dobutamine, and isoproterenol show that these drugs attenuate hypoxic pulmonary vasoconstriction. However, some of these studies also found that at high doses, these drugs cause pulmonary vasoconstriction in normal oxygen lung regions. For these nonspecific catecholamines, this is in keeping with the presence of opposing receptors on pulmonary vessels. At lower doses, you have vasodilatory stimulation of beta-2 receptors causing bronchodilation, which may attenuate hypoxic pulmonary vasoconstriction. Is balanced by the vasoconstrictor effects of the alpha-1 stimulation with higher doses, and that's when alpha-1 is going to predominate and cause vasoconstriction. The use of alpha-1 agonists such as norepinephrine or phenylephrine, both of which cause pulmonary vasoconstriction, is a more effective way of enhancing hypoxic pulmonary vasoconstriction. The second medication that augments hypoxic pulmonary vasoconstriction is listed here. So what medications inhibit hypoxic pulmonary vasoconstriction? Essentially, any drug that's a vasodilator may inhibit hypoxic pulmonary vasoconstriction. All volatile anesthetic agents inhibit hypoxic pulmonary vasoconstriction in a dose-dependent manner, and there doesn't seem to be any difference between ISO, SIVO, or DES and their ability to inhibit hypoxic pulmonary vasoconstriction for equivalent MAC values. Hypothermia can also inhibit this. Acetazolamide can. Inhaled nitric oxide. This attenuates hypoxic pulmonary vasoconstriction by causing localized pulmonary vasodilation. Phosphodiesterase inhibitors, such as sildenafil, impair the breakdown of cyclic guanosine monophosphate, which is responsible for the action of nitric oxide and other vasodilators in the pulmonary artery smooth muscle cells. Nitric oxide donors, prostacyclin. This is a potent pulmonary vasodilator. It has potent pulmonary vasodilatory properties and may be administered either IV or inhaled. Prostacyclin, calcium antagonists, ACE inhibitors, and endothelial agonists. My references for the lecture are listed here. Please reach out with any questions that you might have. I know that a lot of this information can be really dense and complex, so it takes some time to dissect down the different components of the lecture. I think it's really important to spend time thinking about this stuff as you prepare for your C exam and your NCE exam. So thanks for listening, and I'll see you soon.